Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Picture this, right? You're prepping for what looks like a standard, maybe slightly complex foregut case.
Oh, yeah. We have all been there.
Right. So you make your incisions, you insert the laparoscope,
Right.
and, immediately your entire anatomical orientation is just completely shattered.
Absolutely shattered.
Because you expect to see the stomach sitting neatly below the liver, where it belongs. But instead, you are staring at this massive defect in the diaphragm.
It's just a giant hole.
Exactly. And you can clearly see the spleen or maybe a huge segment of the transverse colon just sitting deep inside the chest cavity.
Just actively pressing right up against the pericardium with every single heartbeat.
It's wild. And it is a profound, visceral reminder that the gastro-oesophageal junction is not just some static pipe connecting point A to point B.
No, not at all. It's this incredibly elegant, highly dynamic biomechanical valve.
And when that exquisite system fails, the structural consequences are just absolutely catastrophic.
They really are. And welcome to this deep dive, everyone.
Yes, welcome. Today, our mission is to take a really granular look at the architectural anatomy, the pathophysiology, and, the precise surgical implications of hiatal hernias.
Right, because we have curated this specific deep dive for you, the surgeons and the doctors who are actually dealing with these complex anatomical structures in the operating room or the clinic.
And before we jump in, we do need to explicitly state, before we begin, please note that this content is for reference only. Always follow your local guidelines in clinical practice.
Absolutely. Because to effectively reconstruct a hiatal hernia, you really have to completely reverse engineer the underlying architectural failure.
You aren't just closing a hole.
Exactly. You're restoring a really delicate balance of biomechanical forces.
Okay, let's unpack this. Because before we can even dissect what goes wrong, we first need to establish the baseline of how this anatomical region is actually supposed to function under extreme dynamic pressure.
Right. The baseline is crucial.
Think of the gastro-oesophageal junction and all its supporting structures as like a heavy-duty suspension bridge.
I love that analogy.
It works, right?
Yeah.
Because it has to maintain perfect tension and alignment of the lower esophageal sphincter, the LES, inside a positive pressure environment.
The abdomen.
Exactly. And it has to do this while simultaneously absorbing these relentless, almost earthquake-like movements of the diaphragm every time you breathe, plus those extreme shifts in core pressure.
Yeah, and the anchor points of that suspension bridge are entirely reliant on the crural portion of the diaphragm right around the T10 vertebral level.
Which is where the esophagus actually passes through.
Right. And the right crus is the dominant anatomical player here. It splits, and it literally wraps around the esophagus in this dynamic pinchcock sling, which creates a hiatal canal that normally sits at about 2 centimeters in length. Yeah. But the actual suspension cables, the structures actually transmitting the force and keeping the bridge deck stable, those are the layers of the phrenosophageal ligament.
And our sources really highlight this ligament. It's a bilaminar fibroelastic membrane.
It is not just a simple band of tissue.
No, it arises from the crural fascia, it splits into upper and lower leaflets, and it intimately invests the distal esophagus and the gastric cardia.
It's heavily integrated.
Right. Its primary biomechanical function is to tether that junction, basically ensuring that the lower 2 to 3 centimeters of the esophagus remain permanently locked within the intra-abdominal cavity.
And we really need to emphasize why that specific anatomical positioning is so vital. It's the linchpin of the whole composite anti-reflux barrier.
It's not just about location, it's about physics.
Exactly. The barrier relies on the intrinsic smooth muscle of the LES, the extrinsic sphincter effect of that crural pinchcock we just mentioned, and the acute angle of his acting as a natural flap valve.
But none of those function optimally without that vital 2 to 3 centimeter intra-abdominal segment.
Because the whole system operates on fluid dynamics and transmural pressure gradients. The intra-abdominal placement ensures the positive pressure of the abdominal cavity actually physically compresses that distal segment from the outside.
So it directly augments the intrinsic resting pressure of the LES.
Precisely. If a patient, say, lifts a heavy box, their intra-abdominal pressure spikes massively.
Right.
But because that segment is below the diaphragm, that exact same pressure spike instantly clamps the LES shut even tighter.
It's brilliant engineering. The system uses the exact force that would theoretically drive reflux up into the chest to actually prevent it.
And that self-sealing mechanism is, virtually watertight when the anatomy is intact.
But of course, connective tissue is extremely vulnerable to chronic mechanical stress over time.
Right. Decades of axial loading from swallowing, just constantly pulling.
Combined with the relentless, repetitive motion of respiration, it eventually takes a heavy toll on those fibroelastic suspension cables.
Because that continuous transmural pressure gradient between the abdomen and the thorax is basically acting as a constant underlying force against the hiatus.
So when we transition and look at the general pathanatomy, what we are really observing is a classic structural fatigue failure.
Yeah, the tissues just give out.
The esophageal hiatus progressively enlarges, and the phrenoesophageal ligament attenuates. It stretches out, it loses its elasticity, or it just tears completely.
And the moment that ligament decoupling occurs, the intrinsic sphincter of the esophagus and the extrinsic sphincter of the crural diaphragm are just completely out of sync. They are no longer synchronized at all.
Which makes sense. But let me push back slightly here just to make sure this is crystal clear for the listener.
Here.
If that ligament tears or the suspension cables snap, why doesn't the stomach just drop downward? Like gravity's a thing. Why does it specifically migrate upward into the chest?
What's fascinating here is how rapidly the physics of the thoracic cavity actually exploit that structural decoupling.
The vacuum effect.
Exactly. The thorax is a negative pressure environment. It acts like a literal vacuum, constantly pulling against the positive pressure environment of the abdomen.
I see.
So once the tethering of the phrenoesophageal ligament is compromised, that physiological barrier is just gone. The pressure gradient literally sucks the abdominal viscera upward into the mediastinum.
And it pulls the peritoneum along with it.
Right, which forms a true hernia sac, invaginating through that widened hiatus.
So the structural integrity is basically overpowered by the body's own resting pressure gradients.
Exactly.
And because the attenuation of the phrenoesophageal ligament is, it's rarely perfectly uniform all the way around, the specific mechanics of how it fails dictate the actual clinical presentation.
Which brings us to the different types.
Right. We see this play out in the distinct profiles of the sliding versus the rolling hernias, or type I and type 2. Let's start with type I, the sliding hernia, because that accounts for the vast majority of cases, right? Upwards of 90 to 95%.
Yeah, the vast majority. In a type I failure, the entire GEJ and the proximal stomach migrate straight up, axially, into the posterior mediastinum.
The whole thing just slides.
Right. The ligament elongates circumferentially, and the biomechanical consequence of this straight upward slide is the total destruction of that composite pressure barrier we talked about.
The angle of his becomes obtuse?
Exactly. The LES is stripped of its intra-abdominal positive pressure augmentation and is just left stranded up there in the negative pressure environment of the thorax.
So functionally, this completely uncouples the crura and destroys the pressure barrier. The physiological result is just profound, intractable reflux, right?
Yeah, classic reflux-dominant symptoms. The acid barrier simply ceases to exist.
But here's where it gets really interesting. When we contrast that axial displacement with a type 2, which is the pure paraesophageal or rolling hernia, the anatomical failure is highly localized.
Very localized. In a type 2, the primary anchor of the suspension bridge actually holds. The GEJ remains tethered perfectly in its normal subdiaphragmatic position.
Okay, so the junction stays put.
Right. But a discrete, usually anterolateral defect forms in the phrenoesophageal ligament. It basically creates a window.
A window right next to the esophagus.
Exactly. And driven by that same transmural pressure gradient, the highly mobile gastric fundus rolls up through that specific window into the thorax,
taking that peritoneal sac with it. And crucially, our sources note that as the fundus herniates alongside the normally positioned esophagus, it actually undergoes a counterclockwise rotation.
That rotation is the key detail.
Right. Now, functionally speaking, the huge irony of a type 2 is that despite a massive portion of the stomach sitting inside the chest cavity, the patient might present with minimal to no reflux compared to a type 1.
Which sounds completely counterintuitive, right?
It really does. Can you clarify why that happens? Given the sheer size of the hernia, why is the reflux better?
Well, because the GEJ is still firmly anchored in the abdomen in a type 2, the LES retains its positive pressure environment.
Oh, okay.
The intrinsic and extrinsic sphincters are still roughly aligned, so the anti-reflux barrier is largely intact.
But they trade one problem for a much worse one.
Exactly. You substitute the chronic mucosal irritation of acid reflux for a significantly higher, much more dangerous risk profile. The herniated rotating fundus creates a massive mass effect up in the mediastinum.
You're dealing with acute mechanical obstruction.
Right. As that counterclockwise rotation progresses inside the really confined space of the hiatus and the mediastinum, the risk of a gastric volvulus spikes exponentially.
The stomach literally twists on its own longitudinal or mesenteric axis.
And that compromises its own vascular supply.
Wow. So the presentation shifts entirely. It goes from a manageable quality of life issue with reflux to an acute threat of strangulation, ischemia, and perforation.
It is a profound mechanical trap. And the scary part is those distinct mechanisms, the axial slide of type Y and the focal roll of type 2, they aren't mutually exclusive.
Right, which leads us to type 3.
Exactly. If the hiatal defect just continues to widen unchecked, the structural failures compound each other. We move into the territory of total anatomical collapse.
So type 3 is the mixed presentation.
Yes, it combines type I and type 2. The hiatus is massively dilated. You have the axial sliding component where the GEJ migrates up into the mediastinum,
dragging the reflux barrier up with it.
Right. And D, simultaneously, a substantial portion of the stomach, like the fundus, the body, and frequently even the antrum, rolls up alongside the esophagus.
And that organoaxial rotation occurs here too, right?
It's severely exacerbated in a type 3. The greater curvature flips superiorly. You often end up with a configuration where the fundus sits anatomically higher than the GEJ within the thoracic cavity.
Which means every single supporting structure, the phrenoesophageal, the gastrophrenic, the gastrosplenic ligaments, they're all stretched beyond their physiological limits or just entirely destroyed.
Completely destroyed.
So the symptom profile for a type 3 must be just a brutal mix of both mechanisms.
It is. The reflux barrier is obliterated, so you get severe gourdie. But the sheer bulk of the herniated, twisted stomach also creates profound mechanical compression.
So they get severe dysphagia, early satiety, intense chest pain.
Right, as that entrapped stomach distends inside the restrictive space of the lower mediastinum.
And then we reach type 4, which is just the ultimate failure.
Yeah, if we connect this to the bigger picture, type 4 is the end of the line. It's massive circumferential attenuation of the crura.
Total structural collapse.
The defect is so incredibly large that it's no longer just the stomach. The entire stomach, plus other intra-abdominal organs, share a common sac in the posterior mediastinum.
Which is exactly what we were talking about at the start of the deep dive.
Yeah.
Just for the surgeons listening to visualize this sheer scale, it's incredibly disorienting to open a patient or insert a laparoscope and literally find a spleen or loops of small bowel or the transverse colon just sitting up in the chest cavity.
Or the pancreas. It's totally, completely migrating upward.
It's terrifying. The bulk of these organs is actively pressing against the heart.
Yeah, the distortion of the normal mediastinal architecture in a type 4 is just staggering. It causes profound cardiorespiratory compromise. It impedes lung expansion. It can even impede cardiac venous return because of direct left atrial compression.
So the risk of life-threatening organ incarceration is at its absolute peak.
Without a doubt. It's not just a hole anymore. It's a total loss of the anatomical compartments that separate the abdomen from the thorax.
So what does this all mean for the surgeon? I mean, knowing exactly which anatomical structures have failed and how they failed, that directly informs the precise steps you have to take in the OR to repair the damage and prevent recurrence.
Absolutely. The operative strategy demands a highly methodical playbook. You're basically reverse engineering the anatomy.
Right. And goal 1 is the total reduction of all those herniated viscera and the complete excision or reduction of the mediastinal hernia sac.
Yes. Reducing the organs is obvious, but excising the sac is the truly critical biomechanical step.
Because that sac is derived from the peritoneum. It's a mesothelial lining that secretes fluid.
Right. It maintains a physical, lubricated space.
So if you just pull the stomach down and leave that peritoneal sac intact up in the mediastinum, you're leaving behind a pre-lubricated, anatomically defined pathway.
Exactly. The very moment intra-abdominal pressure spikes postoperatively, the viscera will just slide right back up that existing track.
So you have to strip that sac out completely.
You must. Stripping it allows the mediastinal tissue to scar down and totally close that dead space.
Okay, so once the space is cleared, goal 2 is the mobilization of the esophagus.
Right. The baseline requirement for any durable repair is restoring that critical 2 to 3 centimeters of tension-free intra-abdominal esophageal length.
Because if the esophagus is under tension, like if it's acting like a stretch rubber band just pulling upward against your repair, that constant axial loading will eventually pull the GEJ back into the chest.
Tension is the absolute enemy of the repair.
Which brings us to goal 3, reconstructing the hiatus itself via a posterior and sometimes anterior cruroplasty. You have to safely reapproximate the crura to recreate the proper caliber around the esophagus.
But this raises an important question, and it's heavily debated among surgeons. How much tension is too much tension when doing a cruroplasty?
Because we established earlier that the crural diaphragm is a relentless dynamic muscle. It never stops moving.
Exactly. Understanding the dynamic pinchcock nature of the crura is essential for anticipating post-op complications.
If the defect is massive and you force the crura together under high tension, the rigid, non-absorbable sutures will just cheese wire right through the muscle fibers the next time the patient coughs.
Which is why surgeons frequently have to utilize pledgets to distribute the force or integrate biological or synthetic mesh.
To bridge the gaps that can't be closed primarily. Because if you make it too tight, you induce severe postoperative dysphagia.
But if it's too loose, the pressure gradient exploits the weakness and it recurs.
It's an incredibly fine line. And once you've sized the hiatus, you move to goal 4, reconstituting the anti-reflex barrier.
Right, because the dissection naturally disrupts the native supporting structures. You have to artificially recreate that high-pressure zone.
Through a fund application, like a Nissen or a toupee wrap or a gastropexy, you are artificially reconstructing the phrenoesophageal ligament's job and forcing the LES back into a positive pressure zone.
And you have to meticulously tailor that wrap to the patient's preoperative esophageal motility.
Right, a weak esophagus can't push through a tight 360-degree wrap.
Exactly.
It's just a brilliant orchestration of reversing the structural failure. And, that concept of tissue dynamics brings me to a final, somewhat provocative thought to leave you with today.
Oh, let's hear it.
Well, we know the original phrenoesophageal ligament is this highly dynamic fibroelastic membrane. It acts as a shock absorber that perfectly accommodates breathing and swallowing. But as surgical techniques evolve, how might future biomaterials or repair methods actually mimic this elasticity?
That is the big question.
Right, rather than just rigidly closing a dynamic hole with static sutures or stiff mesh.
Yeah.
How close are we to repairs that truly mimic the dynamic engineering of the original hiatal complex?
Moving from static structural reinforcement to true dynamic physiological restoration, that is the next great frontier in hernia repair.
It's definitely an incredible space to watch. Well, we hope this dive into the architectural mechanics of the gastro-oesophageal junction and hiatal hernias has given you a sharper lens for your next operative case.
Absolutely.
And if you found this clinical deep dive valuable, please do not forget to share it with at least one of your surgical colleagues or medical friends to help spread the word. The discussion really grows because of you.
Yes, please share it.
Also, take a moment to check out our YouTube channel and our other social media pages for more in-depth content. And if you're hungry for more, definitely check out our previous season and past episodes. We explore some very relevant, fascinating medical topics there.
There's a lot of great stuff in the back catalog.
Definitely. So, the next time you evaluate a widened hiatus, remember, it's not just a structural gap. It is a complex mechanical failure caught in a relentless battle between intra-abdominal pressure and thoracic vacuum. Thanks for diving deep with us. We will see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.